A very good afternoon, everyone. It is with great honor and pleasure to welcome you all to this 27th Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussions and dissemination of knowledge and bringing all experts together across the country for managing tuberculosis. On behalf of the National Institute of TB and Respiratory Diseases, I extend a very warm welcome to our esteemed Deputy Director General TB, Central TB Division, Dr. Shobhini Rajan and her team. We welcome you, ma'am, and it will be our honor if you can speak and address the gathering today. Over to you, ma'am. I think she will be, she's busy in a meeting. I think she will soon join us again. I would also like to extend a heartfelt welcome to the directors and representatives from NIRT, NTI, state TB officers, esteemed faculty members from medical colleges, district TB officers, medical officers, pediatric TB specialists, and all healthcare professionals participating in today's session. Now, let me please introduce the faculty from NITRD. I am Dr. Bhumika Dhingra, Specialist Pediatrics at NITRD, and I will be moderating today's session. And with me is Dr. Neeta Singla, Head of the Department of Epidemiology, NITRD, and also Nodal Officer for Eco Clinics. To my right is Dr. Alok Yadav, CMO, NFSG, and Pediatrician at NITRD. The national expert for today's session is Dr. Sushil Kumar Kabra. Sir is consultant at Apollo Hospitals, New Delhi. To formally start this important session, I now have the honor of inviting our respected and visionary director, Dr. Upasana Agarwal, ma'am, to deliver the inaugural address. Over to you, ma'am. Ma'am, I think you're muted.
Thank you very much, everyone, for being presented by AIIMS Bhopal, and the moderator is no one, and the expert is actually Dr. Kabra, a very senior and respected pediatrician. I welcome all the participants who take out time to attend this very important session, and thank you so much. Please, back to the dais.
Thank you so much, ma'am.
Madam, you're not audible.
I'm sorry. So without any further delay, we would now start today's session. Today's presenting team is Department of Pediatrics, AIIMS Bhopal, and the case presenter is Dr. Shivangi Sinha, Resident Department of Pediatrics at AIIMS Bhopal, and the case expert is Dr. Ambar Kumar, Additional Professor, Department of Pediatrics. The didactic lecture will be covered by Dr. M. Mohnish Darshan. Over to the team, AIIMS Bhopal.
Good afternoon, ma'am. I'll be sharing my slides.
Before we start this session, I will request all to please take up the pre-test questionnaire, the link for which has already been shared in the chat box. Yes, Dr. Shivangi, your slides are visible. Yes.
Thank you, ma'am. Good afternoon, everyone. I'm from a resident from AIIMS Bhopal. Today, I'll be presenting a case of tuberculosis masquerading as a thoracic malignancy. So, moving forward, this was a 2-year-old male who was first found out of non-contaminated.
Dr. Shivangi, Dr. Shivani, you can put
Yes,
your
ma'am.
video off. I think because the bandwidth is not
Okay,
enough.
ma'am. Okay, ma'am.
Yeah, thank you.
Yes, ma'am. Okay. So this was a 2-year-old male child who was the firstborn out of non-consanguineous couple who was apparently well 1.5 months back before presenting to the hospital when he developed cough, which was non-productive and had no diagonal variation or postural variation. It was also associated with fever, which was intermittent, documented for 103 degree Fahrenheit, and used to improve on medications. The following history was not associated with any weight loss, night sweats, or any other systemic involvement. There were no history of tuberculosis in family or tuberculosis contact. And the child did not have any similar episode in the past and did not require any hospital admission previously. Uh, 10 days prior to the first admission, the child developed fast breathing. For these complaints, the child was admitted in the outside hospital and had received multiple IV antibiotics. The radiological investigation outside had showed right-sided hemithorax, which was followed by FNAC being done for the child that showed presence of atypical cells, and the possibility of pleuropulmonary blastema was given in the patient. With these complaints, the child was referred to multiple other hospitals and finally reached AIIMS Bhopal in February. The birth history was insignificant and he was vaccinated till 2 years of age as per national immunization schedule and had attained all developmental age-appropriate developmental. The nutrition history showed calorie deficit of 22% and protein deficit of 8% according to ICMR charts. Child came to us, the child was febrile and had significant respiratory distress, which was evident by presence of tachycardia, tachypnea, and work of breathing. Also, hypoxic required non-invasive ventilation support. Documentary was suggestive of severe acute malnutrition with weight for height set score of minus 3.38 3.38 that showed significant weight deficit, which was consistent with the acute illness. However, the parents had not given any history of weight loss. A general physical examination showed pallor was present. However, there was no icterus, clubbing, cyanosis, or lymphadenopathy present in the child. The detailed respiratory examination showed presence of trachea was shifted to the left side, and there were decreased respiratory movement on the right side of the chest, owing that the pathology was on the right side. And these findings were confirmed on palpation and associated there was decreased vocal fremitus on the right side. And percussion, the dull note was heard in all areas on the right side. However, the left concomitant left areas were resonant note. And on auscultation, the air entry was reduced in right infracavicular region and was absent in rest of the region on the right side. These findings were suggestive of that there is some right-sided pathology that is causing distress for the respiratory distress in the child and the symptoms and associated contralateral shift to the left side of mediastinum and trachea shifting, with differentials including either it could be pleural effusion or some right-sided intrathoracic volume occupying lesion was also one possibility in this patient. The cardiovascular examination, para-abdominal and nervous system examination was normal. So after history and examination, the provisional diagnosis that we made was right-sided pleural effusion or mass, etiology under evaluation with the severe acute malnutrition with the anemia. And the primary differential included infection, like tuberculosis, since the child had chronic history of almost 2 months. And one possibility of complicated bacterial pneumonia or fungal pneumonia was also kept. But since the outside report had showed presence of atypical cells, so malignancy was also a strong possibility in this patient, consisting of either lymphoma or pleuropulmonary blastoma or some mesenchymal malignancy like Ewing sarcoma was also thought in this patient. So moving forward, we evaluated the patient. The check that we did in our hospital also showed presence of near homogeneous opacification of right hemithorax and associated left foot deviation of which was also corroborated with ultrasonography that showed presence of large heterogeneous hypoechoic lesion with the few echogenic focus and with complete displacement of right lung. However, there were no fluid present in the pleural cavity. These findings pointed towards the presence of solid heterogeneous mass rather than a simple pleural effusion. So, before we move forward, we would like to review what all investigations had been done in the patient and what were the interpretation for this. So, we had already discussed that chest radiograph had showed presence of right hemithorax and contralateral shift of mediastinum and trachea, which was corroborated with the USG findings as well. The outside CT report had reported that there was a presence of large non-enhancing septated cystic mass occupying the right hemithorax, which caused right lung collapse as well as bronchial cutoff. These findings were in favor of benign or low-grade cystic thoracic lesion with differential including pleuropulmonary blastoma, congenital pulmonary airway malformation, or large bronchogenic cyst. We had sent gastric aspirate sample for CBNAT in this patient and they were negative. And outside FNAC had showed presence of atypical cells. However, there were no concordance in all the findings. So we needed one histopathological diagnosis as well in this patient. So we moved forward with biopsy for the mass. That showed extensive necrotic tissue, and there were presence of inflammatory infiltrate comprising of lymphocytes, neutrophils, and plasma cells, and there was dispersed collapsed alveoli and fragment of lung parenchyma was also noted. However, there were no evidence of any atypia or malignant cells in the biopsy. And there was no organism also seen, which was evident by that ZN stain for acid-fast bacilli was negative, and fungal elements were also negative on PAS stain. So these findings were non-specific findings. Necrotic tissue can be present in any malignancy, which is rapidly growing malignancy, or it can be evidence of any chronic granulomatous infection as well. So there were here at this point in this case, we had discordant findings. The clinical findings, radiological findings, and laboratory findings were not matching with each other, and we could not establish a confident diagnosis in this patient. The pointers toward malignancy included presence of atypical cells and large heterogeneous mass, which has completely displaced the lung. However, the biopsy was not corroborated with these findings in this patient. And further, any infection diagnosis, we have not found any microbiological evidence till now in this patient. So we again evaluated the patient from the scratch, and again we did the CT for the patient. This was the clenching point in our patient because repeat CT showed presence of multiple enlarged mediastinal lymph nodes, which included right upper and lower paratracheal, prevascular, para-aortic, and subcarinal stations. The presence of necrotic mediastinal lymph node pointed towards the diagnosis of chronic granulomatous infection predominantly, which was also corroborated with the presence of this large hypotense lesion on the CT, which was non-enhancing, and pointing towards that it was necrotic material. And there were also strands of viable lung parenchyma in this. So these findings were suggestive of replacement of right necrotizing pneumonitis. Complete right lung was replaced by necrotizing pneumonia that was causing severe mass effect in the child as well as the respiratory symptoms. So with this, again, we needed one microbiological diagnosis in this patient to know that what is the drug resistant susceptibility in this patient. So we again did FNAC in this patient. This finally showed us the evidence that we were looking for. There were areas of caseous necrosis along with presence of well-formed granulomas, of epithelioid cells, histiocytes, and lymphocytes. And there were also few dystrophic calcifications. ZN stain that was done for acid-fast bacilli was positive. This showed that there is a mycobacterial infection. However, ZN stain can be positive even if there are non-tuberculous mycobacterium. So we needed the concrete evidence of mycobacterium tuberculosis. That is why We had sent CBNAT sample from FNAC. We had also sent from biopsy sample, and we had again sent gastric aspirate, although the previous two gastric aspirate that we had sent were negative. In this, again, FNAC CBNAT was negative, and gastric aspirate acid fast specialized smear was also negative. But CBNAT could detect Mycobacterium tuberculosis in this patient. But along with that, there were also detection of rifampicin resistance in the patient, clinching the diagnosis of rifampicin resistant tuberculosis in the patient. So finally, the diagnosis that we made was right pleuropulmonary mass with necrotizing pneumonitis and necrotic mediastinal lymphadenitis, secondary to rifampicin-resistant pulmonary tuberculosis that initially mimicked a thoracic malignancy. The learning points included that the childhood tuberculosis can present as necrotic mass like lesion closely mimicking thoracic malignancy, and as well chronic inflammation per se can cause metaplasia in the cells. Thus, FNAC can mimic malignancy in the patient. And since we all know that the childhood tuberculosis are predominantly postbacterial diseases, so a single CBNAT, negative CBNAT or AFP does not completely rule out tuberculosis, and thus multiple samplings, multi-site sampling and repeat sampling should be done in any patient in whom we are suspecting tuberculosis as a strong differential. And we should always keep TB as a high suspicion in malnourished children, as in this patient, even without a known contact. And most important was this that the child had rifampicin-resistant tuberculosis. So even if we would have not found the evidence of in CBNAT, as we found later in this patient, we might have undertreated the child and had led to inappropriate treatment in the child. Thus, universal drug susceptibility testing at diagnosis should be done in all patients of tuberculosis to decrease the rising burden of drug-resistant tuberculosis. And in our patient, the diagnostic uncertainty was caused predominantly by a typical FNAC report that drove a multi-hospital referral chain before the child reached to our center. This expresses how convincingly this case mimicked malignancy early on. So coming forward with the treatment for the child, since the child had extensive pulmonary disease, that is why the child was started on longer oral regimen, including levofloxacin, linezolid, clofazimine, cycloserine, pyrazinamide. And in WHO 2025 guidelines, they have given conditional recommendation of giving bedaquiline in less than 5 years of age also. So child was also started on bedaquiline. On follow-up, the child had improved symptomatically. He was off oxygen and had also gained 2 kg weight since the treatment initiation. So in this case, what makes this case interesting is not simply the diagnosis. Child had tuberculosis, the diagnosis of tuberculosis. The interesting aspect is the diagnostic and diagnostic challenge that we faced in this the of disease. Thank you.
Thank you, Dr. Shivangi. May I now request Dr. Kabra to, if he has any questions from the team. Good afternoon, sir.
Thank you. Thank you, Dr. Dhulika. It was well worked up and presented. An important lesson learned is that when there is some case in which we are suspecting tuberculosis and we are not able to make a microbiological diagnosis, in that case, as a general rule in clinical practice, you have to see that review the history, examination, lab findings, and then decide whether there is a need for repeat sampling. And here, the typical thing here was that there is a mass lesion from the whatever ultrasound, X-ray, CT scan, which was displacing the air towards the other side, suggests that there is a airway obstruction which was causing increase in volume. And ultimately, gastric aspirate was positive, suggesting that the lesion was communicating with the airway. So the first thing would be that if you are reviewing the imaging, ask your radiologist, see yourself that whether it is communicating. What is the relationship of this necrotic mass lesion with the airway? If required, you can go for a bronchoscopy. Otherwise, it's a very well worked up case and presented. Thank you very much.
Thank you, sir. Are there any questions from the audience?
Madam, what is the source of where is the source of this drug-resistant tuberculosis? Because the child is only 2 year old. So what about the contact tracing and where did this small kid get the infection, rifampicin resistant TB?
Doctor.
No, ma'am, we could not find any source. We have a screen for the contact mother and father, but we could not find the source in this case.
Sir, any other immunodeficiency in the child? Because again, if there is no contact, I mean, with drug-resistant TB, it is
Yes, ma'am.
like. So
Actually,
did the child have any other
no.
immunodeficiency?
Just on the screening part, looking at the CBC, there was no evidence of T cell deficiency, and immunoglobulin profile was done. That was also normal. However, we have not done the lymphocyte subset analysis. That was the lacking part here. But for routine screening from CBC and immunoglobulin profile, there was no evidence of immunodeficiency in this case, and HIV was negative.
Is there any follow-up with the other resistance pattern? Because it is a R and what about the later LPA or a culture or anything?
LP
Because it is a.
Yes, ma'am. Yes, ma'am. LP was done simultaneously, and INH and levofloxacin sensitivity was there. So that's why only rifampicin resistance was there, and that's why we have started this child on this regimen. And the
So
last follow-up was 2 months back
definitely
only, and so
okay, sir.
the last follow-up is pending. So we'll see the improvement.
Yes, but only thing is it's very, very, confusing why did this child had a drug-resistant TB.
Should we move forward for second presentation, ma'am?
I had one question, ma'am. Do you have any X-rays with you, like on follow-up? Any X-ray at the end of 2 months, 3 months, sir?
Yeah, ma'am. Actually, that we are trying to get from the patient. Actually, patient could not come for follow-up. We were trying to call him, and he's responding on phone, but he's not coming for follow-up. So, but he's doing well, and probably next month he will come for follow-up. Then we can share the X-ray in the group if we can share the X-ray.
So one more question. The standard all-oral regime does not have pyrazinamide. So any specific reason for adding pyrazinamide, or is just a precautionary?
No, there was no other reason, just precautionary. So other 5 drugs were recommended, and pyrazinamide was added, and pyrazinamide was sensitive in the LPA report also.
So LPA doesn't tell us about pyrazinamide.
Not LP, not LP. Yeah, true.
Extended DST maybe.
That is in on the DST, but DST pattern we don't have because the culture was not done in this case, actually. So we have added pyrazinamide as a precautionary measure. But levofloxacin and INH was sensitive in this case.
Number, I have one question regarding the case. I just want to know in the FNSC sample is basically the ZNST is positive, but the NAT is negative in this particular sample, and later gastric aspirate was found as NAT positive and RIF resistance. Is right? And the previously the biopsy which was already done in this children in that particular biopsy also the smear and NAT both are negative. So all these basically biopsy and repeat FNSC was done in AIMS or biopsy was done previously in some other hospital.
First FNSC was done outside, and the first CT was done outside. The rest of the investigation done here in-house. The biopsy was done in-house, and also the repeat FNSC and repeat gastric aspirate was done in-house. So I think the main problem is the quality sputum sampling that was lacking in one or two previous instances. That may be the reason. And sometimes in the second sample, we may get positivity. So quality sputum and timely transport and rapid processing is also very important for getting the positive cases in positive bacillary pediatric cases.
Exactly.
Sir, my question is कि हमने इसको एक ही sample पे we are treating this patient as tuberculosis, or did we have any other sample where TB was demonstrated?
No, but the biopsy finding, FNSC finding is correlating, and the child was responded to ATT also. The 2 month we have, that child responded very well.
The weight gain, etc.
Yes, ma'am. Yes, ma'am.
Definitely, X-ray would be helpful, sir. Only if X-ray can tell us how patient is responding, or maybe an ultrasound where the mediastinal lymph nodes are the size is going down, or a CT, something follow to show that the patient is improving. Then I think.
Ma'am, you are not audible.
If there are any question, the audience can take the questions.
If there are no more questions, we can go ahead with the second presentation.
Good afternoon, everyone. This is Dr. Monish from TM Medical Genetics resident from SGPGM, previous resident from AIMS Bhopal. I would like Shivangi to share the screen. Is my voice audible for everyone?
Yes, you're audible.
So today we'll be seeing a case series which shows various manifestations of cutaneous TB in pediatric population. So coming to first case, a 15-year-old male had presented to us with the complaints of chronic cough, loss of weight, appetite, and low-grade fever with night sweats for the past 3 months. Also, he had this development of gradually progressive hyperpigmented skin lesions, which is distributed in a generalized way over the last 2 months, and presented with main complaints of respiratory distress. Past history was he was a known case of alopecia totalis universalis with a history of recurrent respiratory tract infection since early childhood. There's no history of TB contact, and the family history was found to be not significant or not contributory. So, on examination, the patient had tachycardia, was respiratory failure, had pallor and bilateral significant cervical lymphnopathy. On auscultation, he had coarse crepes, note and bilateral lung fields with moderate splenomegaly on abnormal palpation. So on seeing the skin, when there was alopecia totalis universalis with generalized xerosis and ichthyosis, particularly on the extensor surface, with hyperpigmented skin lesions in a generalized distribution manner, which is seen in both these pictures. Investigations revealed the patient had leukopenia. The TLC is 1740 with neutropenia and significant lymphopenia with thrombocytopenia, as well as there was markers of inflammation like CRP and ESR raised. So in view of recurrent respiratory tract infections since early childhood with severe malnourishment, severe thinness, with leukopenia and the lymphopenia in the initial CBC, we had suspicion of immunodeficiency being underlying cause. So we got a immunoglobulin level done, which showed hypogammaglobulinemia. And also we got a LSSA done, which showed T cell deficiency. So we got X-ray done. Next slide. Shivang. So we got X-ray done. X-ray was suggestive of right-sided dominant bronchiectatic lesions, and we got a CT done, showed extensive bronchiectasis. Can you go to the previous slide, Shivangi? So the X-ray and the CT shows extensive bronchiectatic lesions, and we got a gastric aspirate AFB CBNAT done, which was found to be positive with rifampicin sensitive strain. We got a skin biopsy done, which showed hyperkeratosis with extensive lymphohistiocytic infiltrates and granulomas noted. So the diagnosis was microbiologically confirmed rifampicin sensitive TB, which present in the form of extensive bronchiectasis. But why splenomegaly, hypogammaglobulinemia, and bicytopenia? This made us ponder our diagnosis. So we got an exome sequencing done, which showed a variant in the RAC2 gene, which confirmed the diagnosis of immunodeficiency 73B with defective neutrophil chemostaxis and lymphopenia. So the child was started on ATT with supportive management and was discharged. After 4 weeks, when he again presented with complaints of abdominal pain and loose stools, we had noticed that the cutaneous lesions were resolved partially in the abdominal region and was resolved extensively, had a good response over the lesions in the extensor surface of the lower limb, as you can see in the pictures. So this confirmed the first case of cutaneous TB. Coming to the second patient, a 5-year-old female had presented with complaints of intermittent fever and night sweats for 2 months with a history of poor appetite and significant weight loss. Extensive hyperpigmented spot-like lesions were noted over the torso. As such, there was no history of chronic cough or no history of TB contact, and outside the child was evaluated in the lines of pyroxia of unknown origin and was referred to AIMS. This picture shows the hyperpigmented papillary eruptions over the torso and the proximal extremities. Other general and systemic examination was within normal limits. So we had again repeated our investigations for complete blood count, liver function, and renal function tests, CRP, blood culture, urine protein microscopy and culture, abdominal ultrasonography, X-ray, echo, and the other infective workup, along with bone marrow was done, which was found to be normal. But what did we miss was we had, after getting these done, we had got a gastric aspirate AFB-CB net done, and it came out to be positive for rifampicin to Mycobacterium tuberculosis on the third sample. So the skin biopsy also was done to see what was the underlying pathology in the dermatological point of view. So the showed which shaped superficial and deep dermal lymphocytic infiltrates with basal cell necrosis and vacuolar degeneration, which was actually suggestive of pityriasis lichenoides et varioformis acuta, which is in short known as pleva. So the child was started on ATT in view of the constitutive symptoms, characteristic histopathology, and microbiological confirmation of TB. And at the third month of follow-up, the skin lesions had completely resolved with improved appetite and general well-being. Coming to the third patient, a 10-year-old female who had complaints of fever, progressive weight loss, anorexia, and weakness for 2 months, following which she also developed pustular lesions over the face, palms, and soles for a duration of 1 month and presented to us with the complaints of inability to get up from the bed or stand for 4 days, along with headache, vomiting, and constipation. In short, it was lower limb weakness with headache, vomiting, and constipation. As said, there was no any complaints of any abnormal body movements or uprolling of eyes, which is suggestive of seizures. On examination, the child was pale, thin-built, and painful vesiculopustular lesions of the face and the extremities that progressed to puncture out ulcers with crusting was noted. Initially, this patient was treated outside in a government hospital as a case of warts using these salicylic acid and oral antibiotics. But as such, there was no response to the same. Next. So this images show the vesicopustular lesions in the arms and the soles. Anthropometry was suggestive of thinness with the examination suggestive of pallor. As such, no icterus, cyanosis, clubbing, or no cutaneous markers of TB or BCG. BCG scar was present as fine, found to be normal. Next. So CNS examination revealed severe loss of power in the lower limbs with reduced tone and absence of the reflexes in the lower limb with extensor plantar response. And sensory examination also revealed the impairment of posterior column sensations, especially fine touch, vibration, and proprioception below the dermatomes L1. Cerebellar coordination, and as such, there's no any signs of meningeal irritation. Other systemic examination was found to be within normal limits. Investigations were also within normal limits. Initially, we had a differential of we sent CSF for autoimmune panel to rule out autoimmune disorders like NMOSD and Mogata. Chest X-ray was found to be normal. We got a MRI brain done because in view of vomiting, headache, and next, which was suggestive of multiple space-occupying lesions, especially in the white-gray differentiation zone, with mild edema around the lesions. And also, we got a MRI spine done, which showed previous slide, Shivangi, which showed T2 hyper-intense lesion with T2 dark rim and thick peripheral post-contrast enhancement at the D11 L1 vertebrae level with cord expansion, which is suggestive of transverse myelitis, long segment transverse myelitis. During examination, she had pain over the lower chest region. So we got a CT done. CT was suggestive of bilateral rib osteomyelitis. So a pus aspirate was taken from the local site and was sent for AFB-CBNAT, which confirmed the diagnosis of rifampicin-sensitive Mycobacterium tuberculosis. 2D echo was also done, which showed us vegetations over the left chambers. So, having a diagnosis of Mycobacterium tuberculosis with a microbial conformation with rib osteomyelitis, with tuberculomas, with LETM, this was probably considered to be a case of TB endocarditis. And the child was started on ATT, and gradually over 4 months, the endocarditis resolved, the skin lesions also resolved. Now coming to the last patient, a 7-year-old female presented with pruritic erythematous scaly plaque over the forehead for 2 years with intermittent low-grade fever and reduced appetite for 6 months. Her elder sibling had completed the treatment for TB and 2 years earlier. Examination revealed a forehead plaque and a bilateral level 2, level 3 cervical lymphnopathy with the largest lymph node measuring 2 cross 2 centimeter. Systemic examinations found to be normal. So the chest X-ray was done. It was found to be normal with a normal CBC. Gastric aspirate CBNAT was non-contributory. Skin biopsy was done from the local lesion, which showed dense inflammatory infiltrate with well-formed discrete granulomas composed of epithelioid histiocytes and lymphocytes, which was consistent with the diagnosis of lupus vulgaris. And following the diagnosis, which was made by the chronic morphology, household TB exposure, and the characteristic histopathology, after 6 months of ATT, the lesions resolved completely with improved appetite and generalized well-being. So this table, which summarizes the clinical as well as the radiological and microbiological and the treatment response of these 4 patients, which we described earlier. So coming to cutaneous TB is an uncommon extrapulmonary manifestation of Mycobacterium tuberculosis, accounting for 1 to 2% of the entire cases. It may result from exogenous inoculation, continuous spread from underlying focus, or heterogeneous or lymphatic dissemination, or immune-mediated hypersensitivity response to tuberculosis elsewhere in the body. In India, children constitute a substantial proportion of patients with cutaneous TB. Approximately 18 to 45% of the cutaneous TB occur in pediatric age group, with most common age involving 10 to 14 years of age. So the clinical spectrum is highly heterogeneous and depends upon various factors like a route of infection, prior sensitization, bacillary load, whether paucibacillary or multibacillary, depending upon the host immunity and the nutritional status. Most frequent form in children is noted to be scrophulodderma, followed by lupus vulgaris and varicose acutis. In one Indian pediatric series, scrophulodderma has been accounted for 54.6% of the cases, followed by lupus vulgaris. Because lesions may mimic several infections and inflammatory dermatosis, and the demonstration of bacilli is often difficult in these cases, a high index of clinical suspicion is essential for early diagnosis. So the pediatric cutaneous TB may be broadly classified into the next slide, please. These cutaneous TB presentation pediatric population can be classified into true cutaneous tuberculosis and tuberculosis. True tuberculosis includes tuberculosis canker, scrophulodema, lupus vulgaris, varicose acutis, etc. While the hypersensitive manifestations, which is known as the tuberculosis, can be of lichen scrophulosaurum or papillonecrotic tuberculate. See the scrophulodderma, previous slide showing, is the most common pediatric form. It results from the continuous extension from an underlying focus, usually the tubercular lymphadenitis. Begins as a subcutaneous nodule that softens, ulcerates, and produces discharging sinus tracts and characteristic pucker scars. Next is the lupus vulgaris, which is a chronic, slowly progressive, well-demarcated erythematous or skin-colored plaque with simultaneous areas of activity, healing, and scarring. We know that it shows the characteristic epijelly appearance on diascopy. The other forms are tuberculosis varicosa cutis, which presents as asymptomatic varicose or warty plaques. The canker, which presents with firm and painless ulcer, usually accompanied by regional lymphnopathy. Biliary cutaneous TB is usually associated with disseminated diseases, especially in immunocompromised or immunodeficient children. Tuberculoma gamma is a very rare manifestation of cutaneous TB. The hypersensitivity reactions such as lichen scrophulosaurum and papillonecrotic tuberculosis also present like lichen papules or necrotic crusted papules respectively. Next. So the diagnosis of cutaneous TB is often challenging because the clinical morphology is variable and many forms are paucibacillary, making direct demonstration of Mycobacterium tuberculosis being difficult. So the diagnosis therefore relies on the integration of the clinical phenotype, the epidemiological exposure, the immunological test, histopathology, and sometimes with microbiological or molecular evidence. A skin biopsy shows active lesion for histopathological examination for ZN staining and mycobacterial culture. The typical findings seen in histopathology depends upon the underlying type of cutaneous TB, but mostly it shows the epithelioid granulomas with Langerhans with variable caseous necrosis. AFP detection is more likely in multibacillary forms like scrophulodema, canker, or miliary TB and TB gamma, whereas it is possible as in the case of these hypersensitivity reactions. The TB skin test or the IGRA provides supportive evidence of tuberculosis infection, but does not independently establish the cutaneous involvement. PCR can confirm microbiological conformation, although sensitivity may be limited in paucibacillary disease. Once cutaneous TB is suspected or diagnosed, evaluation should extend beyond the skin. A detailed history of TB exposure and constitutional symptoms, examination for lymphnopathy and organomegaly investigations for underlying systemic focus are important, as highlighted in the last line, which is chest radiography and the review for pulmonary and other extrapulmonary manifestations are specifically recommended. Coming to management, drug susceptible cutaneous TB are treated with a standard multi-drug anti-tuberculosis therapy, which is a 6-month regimen for and of isoniazid, rifampicin, pyrazinamide, ethambutol for the initial 2 months, followed by the isoniazid, rifampicin, and ethambutol for the 4 months. Most forms respond rapidly to appropriate therapy, and improvement of cutaneous lesions may become evident within the first 4 to 8 weeks. Although residual pigmentation or post-inflammatory hyperpigmentation or scarring may persist, especially with scrophulodema. Treatment should simultaneously address any associated pulmonary lymph node or skeletal or extrapulmonary focus, because the extent and the site of the systemic disease may influence the treatment duration. Surgical intervention is not routinely required, but drainage, debridement, or reconstructive procedures may be requiring in few cases involving having large abscesses or persistent sinus tracts. So the take-home points are cutaneous TB is uncommon but important in children. Scrophulodema is the most common form of pediatric cutaneous TB, followed by lupus vulgaris. Clinical morphology is highly variable, and the diagnosis is mainly clinico-pathological. Always look for systemic tuberculosis and treat DS cutaneous TB disease with standard multi-drug ATT. Most cutaneous lesions improve substantially with appropriate therapy. Thank you.
May I request Sir to please come in here and enlighten the House on cases and on cutaneous TB.
Thank you. As it has already been highlighted that it is a small proportion of extrapulmonary TB, and clinical manifestations are variable and diagnosis is challenging. So if a patient has come to a pediatrician and he is finding some skin lesion, so as a general principle, most of the time it is associated with the TB in the other part of the body. Most of it commonly it will be intrathoracic. So if you are finding some clinical suggestion of TB along with that skin lesions, try to explain it by tuberculosis, because that is the principle that if a single diagnosis for a multiple sites. If it comes to a dermatologist, then it is important that instead of going by just the tuberculin or tuberculitis or tuberculic skin lesions, it is important that we investigate the child as a whole for the other sides of tuberculosis. As far as treatment is concerned, it would be same for all in intrathoracic or extrapulmonary TB. So, important learning is that if it comes to a dermatologist, always look for the systemic manifestations of TB rather than restricting it to just by doing a biopsy, because that would be a very challenging. And try to establish the diagnosis from the other sides. It may be gastric aspirate, induced sputum, or other thing. Similarly, if a pediatrician is looking for it, give importance to the skin lesion, but it may be due to TB, and once you treat the TB for the say pulmonary TB or extrapulmonary TB, the skin lesion will improve. Thank you very much.
Thank you, sir. Are there any questions from the audience? Today we have seen how differently cutaneous TB can manifest in different ways. So it was almost like atlas-like pictures. Any questions from the audience? If there are no questions, I will request Dr. Alok to summarize the case once.
So today case nicely presented by the AIMS Bhopal team. So today case is a 2-year-old child which is and complained of the cough and fever from last 1.5 month. Child had no contact history of the TB in the family. Child was previously admitted from some other hospital, get investigation from there, and later shifted to the AIMS hospital. At the time of the admission, child is febrile and have tachypnea at the time of the admission. Child comes under the SAM. When the chest X-ray was done, it saw right-sided opaque hemithorax with mediastinal shifting. USG saw both fluid in the pleural cavity. CT thorax, which were done from outside, saw cystic mass lesions occupying in the right hemithorax, uh, causing completely right collapse of the right lung. When the investigations was done, FNSE shows atypical cell suspicious of the pleuropulmonary blastomas. Gastric aspirate initially was found negative. Biopsy of the mass showed extensive necrotic lesion, but Jordan stain was found negative. At the time of the admission, all the investigation was by the AMC, and when the repeat CT scan was done, it showed enlarged necrotic mediastinal lymph node involving the right upper and lower zone, mass effect causing completely collapse of the right middle and lower zone. So FNSC was done, and in the FNSC shows caseating necrosis. Jordan stain for AB was found positive, but no atypical or malignant cells was present in the FNSC sample. Repeat gastric aspirate sample was sent for the NET, in which TB, MTB was detected and ref resistance is detected. So on the NET report of gastric aspirate, ref resistance treatment of all oral longer regimen was started: bedaquiline, linezolid, levofloxacin, cycloserine, clofazimine, and pyrazine. So these drugs are started on the basis of the gastric aspirate report. Child is performing well, and I think 2 kg weight are also achieved gain of this child. So the main thing in this case is basically childhood TB can be presented as a thoracic mass lesion also, and we have to try every attempt to find out the bacteriologically confirmation in each and every case to get the sample from the multiple site also, like in this case repeat FNSC was done and repeat gastric aspirate sample was taken, in which the rifampicin resistance mycobacterium tuberculosis was found. And the universal DST is the initially tool to rule out the drug sensitivity or drug resistance in this case. And we have to highly suspicious in those children who comes under the malnourishment category, same category. So these are the children who are highly suspicious for the TB. So this is all about the case. So basically the case is of the mediastinal lymphadenopathy, and after FNSC report, it was detected as a resistance mediastinal.
Thank you, Dr. Alok. So today's case, we thank the AIMS Bhopal team for a very well worked up case. We also had the opportunity to see how differently cutaneous TB can manifest. Are there any questions from the audience? So no questions. So I will request Dr. Meeta Singla to please give her closing remarks for today's session.
Yeah, thank you. At the outset, I would like to thank the Central TB Division, Dr. Shobini ma'am, for constantly encouraging NITRD to do these clinics. I would also like to thank the AIMS Bhopal team, Dr. Shivangi, Dr. Monish, Professor Amber Kumar, and Dr. Kabra sir for guiding us through this session. Thanks a lot, and thank you all the participants for being there for the whole time and making this session interesting. Thank you so much, and I would also like to thank Echo India for hosting this. Thank you so much.
Thank you, ma'am. We will keep you. The link for the post test has also been shared in the chat box. We will keep the session running for next 5 minutes so that you all can attempt the post test questionnaire. We will meet again next month with another case discussion where we'll see how TB can manifest differently and how we can change our practice and improve the management of children with tuberculosis. Thank you very much. Please attempt the post-test questionnaire. Thank you.